Good morning. For the next 15 minutes, I'd like to introduce a newly launched TAVI system in Korea, focusing on AcurateNeo2 and Navitor. This is the American and Asian guidelines in choosing the TAVI or SAVA, depending on the age. Above 75 years old, they all agree with the TAVI as first option. Under 65, SAVA is the first option. Gray zone, depending on patient profiles, comorbidities, we can do TAVI and TAVI as well as SAVA and TAVI, SAVA and TAVI. When we choose valve type among 4 kinds of TAVI system in Korea, I always suggest consider 9 clinical conditions to choose valve among SAPIEN, AcurateNeo, Evolut Pro, and Navitor. Risk of alveolar tear, then priority is self-expandable. Risk of leakage, SAPIEN is better. Risk of AV block, SAPIEN, AcurateNeo is better than others. Orifice area, SAPIEN is not good. Self-expandable would be better. Future coronary accessibility, SAPIEN, Accurate. Valve thrombosis, self-expandable. Supraannular design, not intraannular design. Horizontal heart, risk of dissection, risk of coronary obstruction. This is SAPIEN 3 Ultra, intraannular design with short stature. Thus, this is a very good choice of valve for the future TAVI and TAVI. Here's Evolut Pro, is a supraannular design providing wider orifice area. AcurateNeo2 supraannular design provide wide orifice area as well as easy coronary accessibility because we can adjust commissural alignment. And Navitor, intraannular design, but self-expandable. Large cell, future coronary accessibility is good. Orifice area is not so narrow because it has a cylinder shape, wider than SAPIEN. Let's first introduce the AcurateNeo2. Unique feature of this self-expandable valve is top-down deployment process that is different from Navitor and Evolut. This is structure. The first release is upper crown, then arch. Thus, we can adjust coaxiality of the device and ascending aorta before final deployment. Lower crown is final deployed part that is surrounded by active seal. The suture is redundant. Thus, this seal may protrude when it meets the regurgitant flow. Thus, it is very effective to reduce paravalvular leakage. Supraannular design provides wide orifice area. Regarding size, if nominal diameter is 25 millimeter, it denotes the waist diameter. Actual landing zone annulus diameter is 3 millimeter bigger. Up crown is well deployed. The diameter is about 30. This 25 millimeter valve, actually 28 millimeter. Diameter of up crown is 30 millimeter. Please remember, the most important beauty of this system is we can adjust commissural alignment during deployment process. This is good commissural alignment. Post is far from the ostium of coronary RC and left main, about 60 degrees. This is 120 degrees. This is the best orientation. This is the worst orientation. Post is in front of ostium. Thus, you have to make this alignment as good as possible. This is the worst. This is intermediate. How to achieve commissural alignment? That is not possible in other valves, except for incomplete commissural alignment in Evolut. This valve, we can completely achieve commissural alignment. The most important feature is location of free cell. This part is chronicalized with post. Thus, this part should be far from coronary ostium. How to achieve it? First, insertion like this. Second, on the 3-cusp view, you have to advance whole system until the annulus. Then you have to see 2 commissures, 2 free cells on both sides symmetrically. If it appears on the left side only, you have to turn left, counterclockwise. If you see the free cell on the right side, you have to turn right, clockwise rotation. Then you have to make this shape. Finally, on the cusp of left view, you have to confirm the other free cells on the front side. The underlying mechanism is well explained in this scheme. Cusp of left view, the one free cell should be anterior. Cusp of left view is like this. Right and left cusps are overlapped. Thus, free cell and post should be right. The other one is overlapped with crimped valve silhouette. On the 3-cusp view, you have to see symmetric free cell on both sides. The other one is disappears in the crimped valve. After deployment on the 3-cusp view, you have to see like this. The center is back, both on the right and left. Simultaneously, on the cusp of left view, you have to see like this. 1 post on the right side, 2 posts overlapped on the left side. Then you confirm commercial alignment is perfect. Then future coronary accessibility would be very easy. Let me show you Encore Live case performed last month. 89 years old with recurrent syncope and severe ES. Aortic valve calcification is moderate, and Augustin calcium score as well as calcium volume at non-contrast and contrast. 3-cusp view and cusp overlap view. Pre-ballooning is strongly recommended based on the size, just 1 or 2 millimeters less than mean diameter. Mean diameter 23, thus I performed 21 ballooning. The first step is upper crown. The second step is arch deployment. The marker is 7 millimeters above the bottom of valve frame. That should be the annulus. Upper crown is deployed, then finally, then after the arch is deployed. So top down, then finally low crown is deployed. Thus, arch is deployed, the alignment of valve system is well matched to ascending aorta. That is beauty. And the final is just a rapid pacing, rapidly deployed lower crown. Thus, the damage to LVOT is really minimal. Thus, there is no conduction block. It's very rare of the instance of pacemaker implantation. Cusp of left view, you can see the little bit underexpanded valve frame with regurgitation. You can see 1 post on the right, 2 posts on the left. And I perform post-ballooning on the 3-cusp view. The size is matched with the mean diameter of the annulus, well expanded. 3-cusp view, no leakage. Posts are equally distributed. Cusp of left view, no leakage. 1 post on the right, 2 posts on the left, overlapped. Good commissural alignment. Thus, in the future, this patient has no difficulty in coronary access. AR index is wonderful. In this point, the patient has a first-degree AV block, and the membrane septum is very short. Thus, we have some concern about AV conduction block after TAVI, but AcurateNeo is very soft TAVI valve, top-down, minimal damage to LVOT, no conduction block. There is matched comparison of AcurateNeo and Sapien 3 Ultra from 4 German centers. They prepared 472 pairs by 1-to-1 nearest neighbor matching process. The results is shown here. Accurate and Sapien. Immediate results, Accurate is better in terms of gradient, orifice area, ppm. 1 month results is similar between two valves, or stroke, pacemaker implantation rate, and 1 month mortality. There's another RCT, scope 1, to compare AcurateNeo and Sapien 3. 3 years results, all death was equal, but soft endpoints such as orifice area is wider in Accurate, gradient lower in Accurate. Compared with Evolute Pro, this is registry. The conclusion is shown here. AcurateNeo provides higher early safety profile driven by significant lower rate of PPI or leakage. Last month, Accurate IDE trial results was reported. AcurateNeo versus mixed control, Evolute or Sapien control TAVI. But 1 year results was inferior in AcurateNeo than control TAVI. Thus, they analyzed profiles, and they found about 20% of the cases result in underexpansion. That results in the poor results of Accurate arm. After bench test, fully expanded AcurateNeo, good flow, no thrombosis. But underexpanded AcurateNeo, turbulent flow, and easy thrombosis and stroke. Why such kind of event happened? Because of implanters. About 70% of implanters had 5 or less cases of Accurate. Really novice. 50% less than 3 cases. 20% less than 5. Overall, less than 20. Just 10% physicians have case of 20 cases of AcurateNeo. That is very important issue in the TAVI field. Thus, they exclude the underexpanded case about 20% versus 8%. That stroke is definitely lower with well-deployed Accurate. The results are similar to the well-experienced Evolute or Sapien. This message is important post-dilatation, and you have to be well experienced, then you have to make such kind of morphology. This is Navitor, self-expandable, but uniquely, the leaflet is intraannular. They provide the larger cell. Thus, future coronary accessibility is very good, but intraannular self-expandable. It is opposite to common sense, because annulus is always elliptical. This device may be elliptical shape. It's not good in common sense, but they confirm it's not so bad. Here's their video bench test. Of course, the intraannular self-expandable, they're elliptical, but coaptation is good and durability is acceptable. That's the rationale they provide this device. 3 months later, they have active redundant peristent fabric. This schema is all replaced by fibrocellular neointimate. Thus, there is really minimal leakage. They are intraannular design. There's some merit over supraannular design, like Accurate or Evolute, when you consider TAVI and TAVI. When we perform TAVI and TAVI, first valve height is very important. This is all wrapped by leaflet. Thus, in this case, there is higher chance of S-junction isolation and coronary compromise. Compared with Navitor and Sapien, there is a difference. Same intraannular design, but lift and mounting strategy is different. They achieved non-tapered, wide open. Sapien achieved tapered mounting, not so wide. When you compare the Navitor versus Evolute, they are cylinder-shaped. Navitor taper. Even though they are supraannular design, actual orifice area is similar between to each other. To summarize the Navitor implantation technique, pre-dilatation is strongly recommended. Size is dependent on the shortest diameter of annulus, and on the cusp of left view, you have to target 3 millimeter depth. It's very shallow implantation. At 88% deploy log, you have to check the depth and non-uniform expansion. That is a kind of cumbersome procedure. Then final release, and you have to get 3 millimeter. I think it is too shallow. My personal depth is about 5 millimeter. Let me show you one case of Navitor. Multiple comorbidities. Pacemaker is implanted, CVES, and annual diameter is 26. That's Navitor 29 with 11% oversize. That is optimal size. Cusp of left 3 cusp view. Cusp of left view is a base view. Balloon up to 23 millimeter, shortest diameter. Then first, sheath end is around annulus. Then I advance a little bit when the distal frame appears here to minimize damage to LVOT. Then slowly, it's very stable, this system. Here, my personal depth is 5 millimeters. Dot denotes the 5 millimeter above the distal frame. And 8% of deployment, there is a checking point. That you have to check depth and non-uniform expansion of frame. Depth is good, but you can see the frame, the spike is 8. Some spikes are crowded, sparse, non-uniform expansion. Then we have to recapture. This is cumbersome feature of Navitor. Then I deploy once again. Let me show you tips for fixation of system. To avoid upward downward movement of valve is gentle push wire as well as gentle push system. Then whole system are fixed. So you can maintain your ideal depth. And 80% deployment, check once again, depth and NUE. There is no NUE after recapture and redeployment process. Then we can proceed to final release step. The outflow diameter is very big. Thus, after final step, the movement is a little bit great compared with other valves. That is another just cumbersome feature of this system. Then final, a little bit undulation, regurgitation, so I perform the balloon a little bit conservatively. Post balloon can be up to the mean diameter. And final, no regurgitation. No regurgitation. In this system, there is no way to adjust commissure alignment. But in triangular design, a large cell, there's no problem in coronary access. To summarize, two systems, AcurateNeo, safe, no AV block, wide orifice, coronary friendly, Navitor, safe, coronary friendly. I think it may be choice of first valve for future TAVI and TAVI. Thank you very much for considering.